Okay, so we have a big category here. We're going to talk about anticoagulants. And as you can see, we have 6 different drugs. Well, technically it's 7 different drugs because this is 2 drugs, but yeah. So first of all, we want you to remember that anticoagulants do not break down clots. They do not thin blood. So does not break down clots and it does not thin the blood. Anticoagulants prevent clot formation. So that this can be used for patients who have myocardial infarctions, angina, atrial fibrillation, because this erratic heartbeat can cause blood stasis. And if blood is sitting or pooling in a vein, then it can start creating a clot. It can also be used for patients who have indwelling devices because fibrin, however you say it, likes to gather at those devices. Also for patients who have pulmonary embolism, who've had a DVT, stroke, or if they've had or are going to receive orthopedic surgery. So the adverse effects of any anticoagulant is going to be bleeding. This can be local or systemic, and it can lead to heparin-induced thrombocytopenia, which is a shorthand for that is HIT, H-I-T. This is when the body forms antibodies to heparin. Patients can also experience nausea and vomiting as well as cramps. Nursing implications for all anticoagulants are that you need to teach the patient about abnormal bleeding and bruising and fall prevention. So abnormal bleeding and bruising could also include petechiae, which is those little red dots at their ankles or on their mucous membranes. They also need to tell their doctors about any headaches that they may experience. Patients should also use a soft toothbrush because hard or coarse toothbrushes in the mouth can cause oral bleeding, and we're trying to avoid bleeding. And patients also need to avoid being constipated, which kind of sounds funny to say avoid being constipated, but take measures to prevent constipation because constipation can lead to rectal bleeds. Another nursing implication that you need to know that you're not really teaching the patient is that you need to monitor your patient's lab values, so like their H&H. So we have 6 different categories, and this little category over here has 2 different drugs. We're just going to start over here. We have heparin. I'm going to bring it closer so you can read it. Okay, so heparin turns off the coagulation pathway. For our class, we don't need to know the specific factors, but I'm going to go ahead and tell them to you anyway. But just remember that if you are taking the pharmacology test that I'm taking, you do not need to know the pathways, the factors that are affected. So heparin turns off the coagulation pathway, factors 2, factors 10, and factor 9. This is unfractionated. So just remember that. We're going to talk about that in just a second. Heparin is weight-based, and it's monitored by the APTT. The normal APTT is 30 to 40 seconds. So a way that you can remember that the APTT is for heparin is by looking at APTT and knowing that the 2 little t's kind of make an H. So you can remember that that's for heparin. Heparin acts rapidly. It lasts 1 to 2 hours. So since it acts rapidly, it can only be used in the hospital. So you can remember heparin, APTT, which the 2 little t's make an H, hospital use only. So heparin, hospital use only. Heparin H, hospital H. The antidote for heparin is protamine sulfate, and this takes about 5 minutes. Nursing implications are that heparin are admin SQ into deep fat sites, and that you need to rotate the site injections. And you do not want to massage the area after you administer this drug. You also don't want to administer it near any open wounds or incisions, near the umbilicus, which is the umbilical cord, or near any stomas. The next drug we're going to talk about is warfarin sodium, which is Coumadin. Coumadin interferes with vitamin K, and it's available only oral. So this is a nursing implication that you need to let your patient know that they do not want to switch between brand and generic, just because different formulations can be obviously a little different. So don't switch between brand and generic. Warfarin or Coumadin is monitored by the INR, which is the International Normalized Ratio. Normal is 1. But what you're wanting to see with a patient who is taking warfarin is INR of 2 to 3. So 2 to 3 is your goal for anticoagulation. Normal is 1. Nursing implications for warfarin is that herbal products can increase bleeding. These herbal products can include ginkgo biloba, ginseng, feverfew, garlic, and ginger. So you need to ask your patient if they're taking any herbal products as well as like over-the-counter or prescription medicines. The effects of warfarin can take a few days to show up, and they need to be consistent with eating high vitamin K foods because warfarin does interact with vitamin K. Foods that are high in vitamin K include tomatoes and dark leafy green vegetables. Adverse effects of warfarin include alopecia, which is hair loss, rash, and bleeding. So this is a drug, enoxaparin. The brand name is Lovenox. Every person in the hospital gets this drug. This drug is low molecular weight heparin. It affects factor XA, which is fractionated, which is a slice off the molecule. Remember over here, heparin dealt with unfractionated. Low molecular weight heparin deals with fractionated. This is primarily for DVT prevention, and it does not require lab testing like heparin does. So this drug can be used at home. Nursing implications are it's SQ, and typically it goes into the abdomen. It comes in a pre-filled syringe that has this little nitrogen bubble, and it's got this safety feature where you really have to push the syringe in after you administered it to the patient. You really press the syringe in to get the little safety cover to come down on top of the needle. When I was first doing this in clinical, my instructor was like, okay, just keep pressing it. And she told us that my instructor told us that every time she helped a student with this, when we finally got it to click, it was like we kind of were shocked because it takes so much force to get the plunger in to initiate that safety mechanism. So it comes in a pre-filled syringe. You don't have to worry about that. You rotate the sites. Again, you don't massage the area. You're never going to be giving this to a patient in their arm or intramuscularly. The antidote, again, is protamine sulfate. For these patients, it's after the patient receives this, they cannot have an invasive procedure because this is an anticoagulant. And every patient in the hospital gets this. Like I said earlier, doctors actually have to justify why to not give this to the patient. So people are in the hospital, they're laying up in bed, or they've broken their leg and they literally can't walk or get out of bed. They're at higher risk for DVT. And we don't want that to happen. We don't want them to throw a clot and then end up with a pulmonary embolism or, heaven forbid, a stroke. So we give them this to prevent that. So everybody's getting enoxaparin. It comes in a syringe already and goes into the tummy. So there you go. The next drug, I'm definitely not going to be able to say. It's dabigatran. I don't know how to say it. This is a direct thrombin inhibitor, which is activated in the liver. The brand name is Pradaxa. Pretty easy. This is for prevention of stroke or thrombosis. The adverse effects, of course, are going to be bleeding. Nursing implications are that it's excreted in the kidneys. This drug is trying to be like Coumadin over here, but it's less dangerous and it's not linked to food. So it's kind of like warfarin's cousin, but it's not linked with food and it's less dangerous. And this drug is a prodrug. So dabigatran, I don't know how to say it. Pradaxa is a prodrug. The next drug over here is low-dose heparin. This maintains the patency of venous access sites, and it doesn't coagulate the patient. So typically you're going to see this if somebody has like a Hickman line or a line that's not permanently, but mostly permanently in their chest, they want to put something in the line. So like, let's say I have a Hickman line in my chest right here. That little tube that's sticking out, there needs to be something in that tube, and they will typically keep heparin in that tube so that inside where it's in my chest, like let's say it's like right here, inside fibrin, however you want to say it, isn't going to grab on to that indwelling device that's in my chest. So they're going to want to keep that anticoagulant in that line to prevent things from growing on that line. Does that make any sense? I hope that makes sense. So what you're going to do with this, it's typically, they say it's SASH. So you're going to do a saline flush. You administer whatever medicine the patient needs to receive, another saline flush, and then fill the line with heparin. So SASH. I haven't had to do this yet, but that's the typical protocol, is that you want to leave that line filled with something, and that something is low-dose heparin. So the next two drugs, which are kind of the same, they're just different brands. We have rivaroxaban, which is Xarelto, but it starts with an X, so Xarelto. and apixaban, which is Eliquis. I'm probably not saying that right, but who cares? These drugs inhibit factor XA, which is same over here with enoxaparin. It's for strokes, post-op thromboprophylaxis, DVT, and PE. The adverse effects are going to be peripheral edema, dizziness, bleeding, and headache. And there is a black box warning for these drugs that includes spinal hematoma with epidural catheters. So typically, I'm pretty sure that this is the drug where if somebody's receiving an epidural, like for childbirth, and they get a really, really bad headache afterwards, it's because they need to have a blood, they need to have a little blood clot, not blood clot, but a blood infusion injected into that area to form a little hole over where the site is where their spinal fluid is leaking out. I don't know if I explained that correctly, but there is a black box warning for this drug where there's a spinal hematoma with epidural catheters. So anticoagulants, remember, these are going to prevent clot formation. They do not break down clots and they do not thin blood. Adverse effects, obviously it's going to be bleeding because you're trying to prevent a blood clot from forming. And yeah, that's all we have for anticoagulants.